I practice in a large urology group in the suburbs of Philadelphia, western suburbs. My practice is focused on treatment of localized GU malignancies, kidney, prostate, bladder, testis, but also on some of the systemic treatments for patients who have progressed, especially in prostate cancer. Post-RP patients who have confined disease, negative margins, negative nodes, negative seminal vesicles, they have intermediate risk disease, I usually observe. The dilemma is those that have one or more positive margins, extraprostatic disease, disease in the seminal vesicles. We have to decide whether to treat them with adjuvant radiation right away or whether we could just observe them and do early salvage once PSA starts to go up. Certainly high-risk patients, though, that have nodal disease, T3B disease, those are easier because you know that they will recur, they will progress, and so you have to treat them probably early and with either adjuvant radiation or combination of radiation and hormone therapy. I think it depends. So rising PSA, it also has to do with the velocity of this PSA rise. Those that have immediately detectable PSA and PSA starts to rise very quickly, you assume they have systemic disease, and in those patients we usually repeat metastatic imaging. Even if the imaging is negative, you have to follow, and the PSA continues to rise rapidly. Those are the patients that I would consider for hormone therapy, versus those that PSA is fine for a while and then starts to rise very slowly. Those I usually have local recurrence, and we again repeat imaging. If we see the local recurrence, we certainly would consider adjuvant or salvage radiation in that setting. If we don't see anything, again, we're considering salvage radiation, especially if PSA continues to rise. Yes, I do. So I use the Decipher platform in post-RP patients, and for me it's important to identify their risk of metastatic progression at 5 years. Those at high risk, I certainly recommend early radiation therapy based on, at least on retrospective data from Thomas Jefferson, showing that those with high Decipher scores, those that got adjuvant radiation did better than those that got early salvage. And for those at low risk, I sometimes tend to watch. Follow the PSA careful, and if they start to rise, certainly I entertain early salvage when the PSA is well below 0.5. For post-prostatectomy patients with high-risk features, positive margins, extraprostatic disease, high grade, those are the patients that I'm interested in getting a genomic risk.